Hello, David?
Hi. Hi,
Oh, there you are.
Can you hear me?
Yes, we can. So, David, just what are the roads? What is the highway situation right now?
Well, we have some roads that are closed. The Highway 39, which basically runs from Moose Jaw to the U.S. border through Weyburn, through Estevan, it is closed at the moment. But that's where we're having the most trouble, I think, is the area sort of south and a little bit east of Regina, between sort of Moose Jaw, Regina, and heading down to the U.S. border. If you look at the highway hotline map, right now you're seeing red in those areas, which indicates roads are closed. There's also some areas where and the big issue for us is, this heavy snow is one thing, but it's also the wind, which makes visibility a real challenge.
All right. So, David, you're kind of breaking up on us again. Just quickly give us an update again on which roads or highways are actually closed.
The Highway 39 is closed between Moose Jaw and the U.S. border. A segment of Highway 35 is closed, heading south of Regina, and the same with Highway 6, which is north-south from Regina.
All right. David, thanks so much for this.
You're welcome.
David Horth with the Ministry of Highways, updating us on highway conditions. At midday, Saskatoon is reporting light snow, -1, Regina light snow and blowing snow, and also -1 degree.
You're listening to Blue Sky on CBC Radio 1. 94.1 FM in Saskatoon, 102.5 FM in Regina, and 540 AM all across the province.
Well, for some people, medically assisted death is a way for people to take control of how their lives end. And while some say it's empowering, others have questions about who should have access to medically assisted death. As part of our mental health rounds, in cooperation with the University of Saskatchewan, we'll be speaking with a Saskatchewan doctor who can help answer any questions you might have. But of course, today we want to hear from you. Do you think it's important that everyone in Saskatchewan have equal access to medical assisted death? Are you or a family member considering ending life this way? If so, why? Have you changed the way you think about medically assisted death? Or just any general questions you may have, because we know there's a lot of misinformation out there about medically assisted death. So give us a call today. We're at 1-800-716-2221 or email bluesky@cbc.ca. We're also live streaming the program today at cbc.ca/sask and our Facebook pages. If you have questions, just put them in the comment section there and we'll get to them as quickly as we can. Our guest today is Dr. Lillian Thorpe. She is a geriatric psychiatrist and professor of psychiatry and community health and epidemiology at the University of Saskatchewan. Dr. Thorpe spends much of her clinical time performing assessments of capacity in complex patients, but also assesses many patients requesting MAID. She's joined me in our Saskatoon studio, and again, the show is being live streamed on the CBC Saskatchewan and CBC Saskatoon Facebook pages, the CBC Saskatchewan YouTube channel, and at cbc.ca/sas. Get your questions in those social live streams, and we'll pass them on to our guest. Dr. Thorpe, thank you so much for coming in today.
You're very welcome. Thank you for inviting me.
Let's start with the very basics. Just what is medically assisted dying?
So we all die. 100% of us will die at some point, and the question is really how and when. So medical assistance in dying is something that enables a care provider, a physician or nurse practitioner to administer medications that ends a person's life, and that has fairly strict criteria in which situations that can occur, but it's generally anesthetic drugs in high doses that are given mostly intravenously. Occasionally, this might be across the country given orally, but for the most part intravenously. And yes, and there's a bit of protocol around how that happens with paperwork and assessments and so on, but that's in short what happens.
How do you determine whether someone qualifies for the program or not?
Yeah, so what practically happens, so the law is federal that determines how people might become eligible. And of course, it's administered at the provincial level, and each province has its own way of assessing whether people might be eligible. So the eligibility criteria determined from initially Bill C-14, which was then came into being in 2016, determined how this would be. And what it means is, so somebody has to be 18 or over. So there's no MAID for people under 18. You have to have capacity to make your own decisions for health, and you have to be eligible for publicly funded healthcare. So we don't do MAID tourism here, so unlike Switzerland, where people can go for MAID tourism, and you have to be able to make a voluntary request for MAID that's not as a result of anybody influencing you. So within that, it has to be people with pretty bad things that are not getting better. So how the law defines this is serious and incurable illness, disease, or disability, and you have to be at an advanced state of irreversible decline in capability, so not in the very early stages of those diseases, and that illness, disease, or disability causes a person enduring physical and psychological suffering that's intolerable and can't be relieved under conditions that they consider acceptable. So those are the legal requirements. How that is then determined, as in Saskatchewan, would be mostly coordinated through the provincial MAID program, which people can all reach now under one number. So for those of you interested, it's 1-833-473-6243. And so that enables people to have some discussion with a nurse generally to start with, to get some information which can then be sent out to people. And then if it looks like that person might reasonably be eligible, then there would be arrangements made for two people to assess that patient. And the MAID program, it's based in Regina, but it's provincial, has links across the province, and can set patients up with somebody relatively near them that could then provide an assessment. And assessments are all done generally as much as possible in person, if we can. There's some virtually, but more in person.
How often does someone choose medical assistance in dying here in Saskatchewan?
Well, the numbers are really going up. Initially, the numbers were relatively small. So the law came in June 2016. So there were not many people in Saskatoon itself. Like, we might have had maybe 4 people in the first few months, but it's gradually increasing and much more quickly increasing during the past year. So when I look at the stats even of numbers that I've assessed, I looked at my stats before I came, I think it was 943 assessments I did since 2016. So what I see is that these are becoming more frequent, and as people know medical assistance in dying is available, people know that they might approach us, and there's been lots of discussion in media, in social media, and so on, and patients know people that have had this. So numbers are definitely increasing. So it varies. Saskatoon has a lot of assessments. Regina probably somewhat less. We have some of those numbers. I didn't bring them with me today, but certainly increasing, and it's not uncommon now.
How common is it for someone to go through the assessment process and be denied?
So it's actually not very common to go through the assessment process and be denied. It's more common for a person to go through the assessment process and us to say, we're not quite sure. We'd like to do a little bit more assessment here. We'd like to see how maybe something might work to help your quality of life before this is a big decision to make. And so we don't actually have to decide instantly. We might want to look and see if a person still has wishes to go forward with this, if they have appropriate supports in certain areas, pain management, nausea management, and so on. So it is not very common. Actually, now I think it might become more common as it's more well known that MAID is available there, but currently not very common. More common to say, not yet, let's talk about it.
Okay. I want to bring our next guest into the conversation, and I want you to feel free to jump in at any moment. But our next guest has firsthand experience with the MAID program. Siobhan Chinnery supported her husband, Scott, through a medically assisted death in 2019. Scott died at home surrounded by family and friend. Now, Siobhan volunteers with the organization Dying with Dignity in Calgary, and that's where we've reached her today. Siobhan, thank you for joining us today.
Yeah, thank you for having me.
Siobhan, tell us about your husband, Scott. What were the circumstances that led to him choosing a medically assisted death?
Yeah, so Scott was diagnosed with peripheral primitive neuroectodermal Ewing sarcoma tumor in 2018. Pretty rare and aggressive cancer. As soon as he was diagnosed, he knew that he wanted to explore the option of medical assistance in dying. Because he had watched his own father suffer and pass away from cancer in 1994. And he really felt that the lack of quality of life that his father had in his end stages, Scott did not want to experience that. So so we started looking into it and researching and trying to find out more about it pretty early on in his diagnosis.
When did Scott go from, trying to fight the cancer to choosing a more dignified death?
So with us, it was unfortunate, but almost every appointment we had was more bad news. So he went through chemo, very aggressive chemo treatment. It was unsuccessful. Then he went through a very aggressive radiation treatment, unsuccessful. And then he had a debulking surgery, which seemed to, frankly, anger the cancer, and it grew back even faster. So at that point, when they told him that from now on, it was just a matter of keeping him comfortable, which would have been about June of 2019, that's when we got more serious and really reached out and started to find more information and find out the process to get approval.
Well, let's talk about the process for a moment, Siobhan. What was that process like, allowing Scott to choose this?
It was challenging, I have to say. It was difficult to find the information, and one of our learnings was that a lot of people in the medical community are not as well informed as the MAID coordinators. So the people who are actually work in this area that do assessments and that are, of course, very knowledgeable and super helpful, but generally medical people that we reached out to weren't that helpful. So until we found our way actually to the local MAID office, we were working under, say, false information and understanding of what the process was. So once we got to the MAID coordinators, though, super helpful. And the process was that at the time when Scott elected to do this in 2019, you had to have two witnesses of his paperwork. And so he submits a request. There's two people that don't benefit from his death have to witness his request, which then also not great. We had to fax in the paperwork, was the only way to submit it in Alberta in 2019. So I had to try and find a fax machine, which we didn't have. So it was a complicated process. Once the form is all submitted and accepted, then the process starts of scheduling and booking assessments, which we found, assessors like your guest today, they have lives, they have careers, they have family, and they too take vacation. And so Scott was needing his assessments in August of 2019, and there was just not a lot of people available to do those assessments through, I would say, a high vacation time of year. And so his paperwork was submitted August 4th. He also requested a waiving of the 10-day waiting period because he was in a lot of pain by the time his paperwork was submitted. His first assessment happened in the hospital on August 16th, as by this time he had actually been admitted to palliative care in the hospital. And then the second assessment was on August 19th. I had him back home by then. And then his MAID was provisioned on August 20th.
When you and Scott discussed this, what did Scott want at the end? How did he want this to go?
Well, he was a pretty fun guy. He was larger than life, and so his idea originally was that we would have like a dinner party or something and have friends over and celebrate life. And then he would just go upstairs or something and have the provisioning done, which of course isn't how it works. He also wanted it to be in the evening. And like I said, these people have lives, they have careers, and we couldn't schedule it in the evening. So, and then also his cancer, which was shocking to us both, really took over and he went downhill very quickly. And so by the time he had it, he was bedridden at home in a hospital bed we put in our family room, and so not at all how he had envisioned it from that perspective. But the part that he did like and was wonderful for all of us, he was surrounded by family. We were all there holding his hands, me, his two daughters, his mother, his brother and sister-in-law, and then two very good friends of ours were there for support as well. So we were all together around him listening to CBC radio, actually, and they were doing a morning special on Rush, which was one of his favorite bands of all time. So it was perfect. And he said his goodbyes. He tried to leave, impactful words of wisdom for our two daughters, and just shared so much how much he loved us all and how happy he had been with his life, but that he was completely at peace with this decision.
Now, Siobhan, you wrote a really powerful blog post about the last day with your husband. Tell us about the experience from your perspective.
Yeah, so from my perspective, to be honest, I was terrified. I was from the beginning worried about actually sitting there experiencing his death. It was pretty, I don't know, I guess I worried. It was more scary in thought than in the actual situation or experience itself. It was difficult. I mean, you sit there like the night before knowing it's the last night you're going to have with your husband. We had been together nearly 30 years, married 25. Like, it was really, really hard. It's hard to know that that's your last night together. And I remember, I'm a planner, I'm a doer. So I was like, I got to do this, I got to do that, getting things ready. But then when the doorbell rang and the doctor and the nurses arrived, it was just very, all of a sudden hit me like, this is happening, this is now. And of course I just started to cry, but the doctor and the nurses were just so comforting, so knowledgeable, so supportive. I can't say enough about them. They were really, really wonderful. And I sat with Scott and held his hand for the whole time, and actually sat for quite a while after he was gone holding his hand, which was another thing I thought I would be kind of afraid of, but I was so at peace and comfortable sitting with him through that. It was really wonderful. In fact, it's hard to say it was wonderful, but it really was. It was very peaceful, very loving moment, probably honestly one of the closest moments we had in our whole lives together. It was very beautiful.
I'm asking you to speculate now, Siobhan, but how do you think that experience differed from had your husband died of the disease, had come to his end that way instead?
Well, I think I have a very good idea. I was with him when his father passed, and we were called home to New Brunswick when his father was at the end. And when we arrived, we couldn't communicate with him. He was already pretty much unconscious in pain relief with a lot of drugs. And so going home, there was no conversations, there was no communications, there was no loving goodbyes or hugs or things like that, because he was pretty much gone as a person. His body was still there, but as a person that you could engage with, he was long gone when we got back for that. And I know too, for us, Scott was a big guy. He was 200 pounds even when he was very ill. And the last day was really a struggle helping him around the house. And so if it had gone on longer, he wouldn't have been able to be at home. I just couldn't have managed it at home on my own. So he would have had to have gone to hospice or something like that, or palliative care. In the hospital, he wouldn't have wanted that, but there's no way I could have maintained him at home for another couple weeks or longer. It would have been very, very difficult for us all.
Siobhan, we're going to take a real quick break. Can you stick around for a few minutes?
Yeah, you bet. Thank you.
Okay, we're going to take a quick break now. David Horth joins us, and I think David is going to bring us an update on the roads condition. David Shield, pardon me. David Shield is here with an update on the road conditions and headlines. Hello, David.
Hello, Garth. Well, the road conditions are not great right now. The Highways Hotline map is a sea of red right now in the southeast. Many roads southeast of Moose Jaw and Regina are closed. That includes all roads around Estevan and Weyburn and Highway 39 to the U.S. border. Highways says visibility is poor in the area and roads are ice covered with heavy snow. Meanwhile, many roads are under a travel not recommended warning around Regina. That includes Highway 1 westbound from Regina all the way to Mortlach, Highway 1 eastbound from Regina to Balgony, sections of Highway 6 southbound from the city, and Highway 11 on the west side of the city. Poor visibility is also being reported in many sections of the southeast, including all roads around Fort Capel and Melville. Anyone who is venturing out on the road should be very careful and drive slow. And I'll have a full newscast for you coming up at 1 o'clock.
Great. Thanks, David.
You're welcome.
Okay, and back to today's conversation. We're talking about medical-assisted dying in Canada, or MAID program. Our guest right now is Siobhan Chinnery, who supported her husband Scott through a medically assisted death back in 2019. Siobhan, if you could do it all again, is there anything you do differently when it comes to the MAID program?
Yeah. What I would do differently was work on getting all the paperwork and all the assessments and all that done earlier. So Scott wanted to, after we had been on a trip, we got home and he had a downturn really suddenly while we were away. So we came home, he said, just let me wait and see if I get my strength back. And if I do, then we'll wait. And he didn't. And so he made the decision on August 4th to submit that paperwork. I think I would have rather, back in June when we knew that he was really just going to be in a getting comfort sort of medical care. We should have done all the paperwork and assessments at that point. So he was all approved and ready to go. And then you can schedule your date later. You can schedule, reach out to the MAID coordinators and schedule much later once you have approvals. But I think really we would have started the approval process sooner.
And finally, what advice do you have and do you offer other people who are considering MAID?
Much of the same. I mean, I really recommend getting to the information as soon as you can and understanding the process. There's also end-of-life planning, which, of course, I volunteer at Dying with Dignity, so there's lots of seminars and that type of thing that Dying with Dignity offers to help people understand end-of-life care and advanced care planning, which is really, really important. And then again, just making sure if you do have that option, you have an illness that's not getting better, I would get the approvals, get the process done, and get it done in advance.
All right. Siobhan, thank you so much for joining us.
Thank you. Thank you very much.
Siobhan Chinnery supported her husband Scott through a medically assisted death in 2019. Dr. Lillian Thorpe is with us. Dr. Thorpe is a geriatric psychiatrist and professor of psychiatry and community health and epidemiology at the University of Saskatchewan. What do you think of what we just heard from Siobhan? Is her experience what one would expect? Was there anything stood out for you?
Yeah, so I think the experience, the everything's changed a little bit. So that was back in 2019. So since 2019, and it was in Alberta, I understand too. So things are a little bit different across the country depending on where you live. So if you're in Saskatoon right now and you are track 1, which means you have reasonably foreseeable natural death, then actually it's usually within a few days that you will have your assessment. And for me, when I hear it's often the same day or the next day if it's in town, so it's a fair bit quicker if you're living in a place in a fairly urban setting, and also this is all improved a bit over time. So it would not be that slow these days, mostly here. So especially Saskatchewan is very, very well coordinated. I think it was very clever the way it was set up, because this is all coordinated through the 811 health line, and the people who work there also have quick contact with others that access all sorts of health resources, and they have contacts all throughout the province. So actually Saskatchewan is really quick to be able to respond, and I think has really good centralized processes also for safety, because with medical assistance in dying, it's not only about autonomous decision making at the end of life, it's also about safety. And so we want to make sure that people have access to assisted dying, but also that people don't make these decisions rashly without thinking about them. And we want to make sure we have careful processes, and having a centralized process such as the provincial MAID program is actually a really good way to do this. So it's very coordinated. Everybody really is, they know who everybody is. They're able to make sure there's quality control. They can overview things that are happening, and then they know who everybody is, and they can assign people. They can contact us quite quickly to be wherever we need to be to assess people. So it's actually quite quick for us now, much quicker than that. So that's partly time passed, partly I think part of having a really wonderful provincial MAID program. And many of us, of course, not full-time, we have other jobs, but they coordinate things really well and do a good job. So, but the idea, those sort of sentiments that that somebody's dying, this is your last night, this is always difficult. People talk about this, and I don't know, is it more difficult that way, or is it suddenly that you find your spouse dead and never had a chance to plan? So I think at the time it's difficult to know this is happening. It's like, the axe is coming down at some point, and you know when it is. That's hard, but in the long run, you have more time to prepare for this. You probably have less trauma afterwards, because much of the grieving happens as this is happening. This is very prepared. This is very controlled. This is a very peaceful death. Bad things don't happen. You don't choke. You don't throw up. You don't, have incontinence. So it's a very controlled and peaceful process. You have your family there. There's lots of discussion beforehand where we learn to come to terms with the death. And many of us don't talk much about death. It's a big problem in our society that we all die, but we don't want to talk about death. And especially now that death has become very medicalized, that deaths over the last century became very much hospital-based, and we don't see people dying anymore. And so MAID has somewhat changed that gradually, and our percentage of deaths in hospitals coming down lately. And I think it's partly due to MAID that we want to make sure that the dying process is a natural one, and as much as natural as possible, and is a good one for everybody involved, the families, the patients, and so on. So those things that Siobhan talks about, very much sort of those sentiments that are very common. It is really always nice to hear those things. We do a lot of quality assurance stuff here as well with patients, and our what we've done, and I think we've improved things a lot, because people like Siobhan have been willing to speak and let us hear about their experiences, so that we can always get better.
Okay. Folks, if you have just joined us, our conversation today, it's part of our mental health rounds series here on Blue Sky. And today we're talking about medical assistance in death, or MAID. And I know that there are a lot of questions about the MAID program out there. There's a lot of misinformation floating around. Here's your chance to get the facts. Give us a call. It's 1-800-716-2221. You could email bluesky@cbc.ca. We're also live streaming today's program on our CBC Saskatchewan and Saskatoon Facebook pages, as well as our YouTube channel, so you can follow along there. Put your questions in the comment section, and we'll get to them as quick as we can. Let's go to the phones now. Keith is in Saskatoon. Hello, Keith.
Oh, hi there. Yeah, I'm not sure why dying is still such a taboo subject in our country, but I have been with people that have had assisted dying, and one of my friends was one of the first people to apply And I'm really glad that it's available to me should I need it.
What would make that decision for you, Keith? What would have to be going on in your life?
Well, I have had a near-death experience, so I was in a coma for quite a while. When I came out, I wrote my own obituary and eulogy and made sure my will was up to date, and I just see it as a path that we all got to take it. I mean, might as well get ready for it, might as well think about it. And so, yeah, I don't see a problem with it. I've thought of different ways of doing it before it was legal. So, yeah, I just don't understand why the taboo. I mean, we all have to do it.
Keith, thanks for the call. Thanks for joining us.
Yeah,
Dr. Thorpe, any thoughts?
Yeah, I just wanted. It's an interesting comment you made. You thought about doing it before it was legal, and I that is what's happened previously. You know, when people were in terrible states, sometimes they did do it on their own, and it can be highly traumatizing for someone to come home and find somebody deceased, somebody who'd hung themselves, or somebody who'd taken a gun to their head, and it's highly traumatizing. And when people do this on their own too, they don't have really the chance to talk this through with someone else, and oftentimes things feel a little better when we talk to someone. And with MAID, when people they have to actually talk to someone, they have to talk to a few of us. They talk to the initial contact who gets that call from them. They talk to at least 2 different providers, assessors, and sometimes just the idea of talking to someone is extremely helpful. So in some way, it's a risk. It's a harm reduction thing that we really don't want to have families come home to someone who's dead, and it's really traumatizing. Young children, spouses, and so on. So that is something that is hopefully going to happen less now. With next year, so there was supposed to be a change in the law to allow MAID for someone mental illness starting March of 2023, which was now deferred by a year to 2024. So that would then allow people with someone mental illness. And my hope would be that people who are suicidal will then actually maybe less likely respond to really impulsive things, but be able to talk people through what have they tried, what has helped. Maybe they haven't got all the information about what could have happened and so on. So I'm hoping that this might itself be to some extent a harm reduction thing. People may be less likely to end their lives by suicide and maybe find some solutions that can help them live better lives.
You broached the topic, and I want to talk about this. Next year, MAID will be expanded to people with mental health issues. And there's a lot of concern about that. And that's one of the reasons it's happening next year instead of this year. And I guess if you could sum up the concerns, the legitimate concerns, is that the question is somebody who's dealing with mental health issues like severe depression, which would be one of the criteria for the expanded MAID, are they ipso facto unable to make the decision because of the mental health issue?
Yeah, so that's always the question of somebody so depressed, can they not make their own decisions? So it's possible that when somebody's in the midst of a severe depression, they actually don't see life very clearly, and that is absolutely true. So you everything seems much worse when you're very depressed. So, but there are people who have every treatment known to man for years and years, and their response is very little, or even over time, sometimes worse. So those people may have a very good idea that they actually have tried, they've been willing to try lots of things, they're not getting better. So this is, and that they don't want the situation to continue. So that's the kind of situation that will be possible for people to then access death. So we've had much discussion about how we talk about incurability and irreversibility, those kinds of things, and those are the big questions in psychiatry. So we've had a committee under Health Canada that I was involved with. We worked very hard to try to define how we would decide some of those concepts, and that's all available online right now. And it is going to involve extensive discussion and exploration of what's been tried, and it's not going to be automatic. So it's going to be a careful process. And one of the big worries for many of us, of course, is actually there's going to be a lot of time needed to assess people that maybe when they're quite young, they're feeling really impulsively miserable about their lives, and they're going to ask for this, and there's going to have to be a really good system to assess those folks to make sure that they are in a situation that's not going to get better. It's going to be time intensive. We already have poor access to psychiatry across the province. We have hugely long waiting lists everywhere. Do we take some of those people out to be in part of these committees that are going to look at, is this an appropriate person that should be eligible for MAID? So there's going to be a big time issue to this. But it is not going to be a simple thing. Now, in places like Europe, where MAID for soul and mental illness has been legal, very few people do this. And in the end, it's an option that people have that doesn't happen very often. So I think that's what's going to happen. But I also think that many people will apply that will increase considerably workload of those of us who are going to be assessing it.
As the law stands now, and this is a question from YouTube, as the law stands now, would someone having a major depressive disorder be ineligible for MAID?
No.
As it stands now?
So right now, no, because a person could have a severe medical illness. You could have, say, severe lung cancer, for example, and severe lung cancer, and you have major depression. So even just because you have major depression, that doesn't take away your ability to choose options throughout your life. So you may be completely aware that have got lung cancer, you've tried all these chemotherapies, all kinds of treatments through the cancer clinic, they're not getting better. Even although you're depressed, you might still be able to understand that. So just because you have a mental disorder does not automatically make you incapable of having medical assistance in dying. Right now, though, you have to have a medical disorder, not a soul mental disorder, that is the underlying problem. And so it can't just be soul mental illness. And that is what's going to change in March 2024, that at that point it could be sole mental illness but not necessarily medical. So this is a super good idea. We often struggle with this. We want to make sure people do have access to autonomous decision making, and just because someone has some kind of a mental disorder doesn't automatically make them ineligible for making any of their own decisions. I mean, if you look at the prevalence of mental disorders, it's really high, and lots of people have anxiety, people have depression, and they can very reasonably make decisions about their medical disorders, and they do so all the time.
Okay. And we're going to go back to the callers in just a moment, but something I want to canvass with you before we run out of time today. How do you ensure that someone who's applying for MAID isn't being coerced by family, or at least having it strongly suggested by family, or that they're not just doing it so that they aren't a burden?
Yeah. So the direct coercion, it is important to have a chance to talk to people independently without anybody else around. And if one isn't sure, one has multiple discussions with a person. And because sometimes people can be impacted, their wishes, their choices can be impacted by family members, even not immediately in the room. So there have to be pretty good discussions with people to ensure that they really know what's going on, that they have their own wishes that are driving this. And that is an important thing to do. Now, the more common thing in undue influence is people trying to convince family members not to do this. That is far more common than people influencing you to do this. Really rare, but always a concern, and we have to make sure that's the case. So occasionally I've had situations where I've interviewed a patient with a family member in the room. I've had to ask them to leave because the family member wanted to answer the questions and really add things to the interview that would made it hard for me to know from whom this was coming. And so it does have to come from that person. Our responsibility is to ensure that that is the case. And that might mean multiple chances to talk to the person. There are already two of us that do this, but even one of us might need to talk to the person in different situations, in multiple situations, to ensure absolutely that this person is making this free decision. Now, being a burden to someone else, that is actually a normal thing. So if I were dying of a slow, miserable cancer, I'm in the palliative care unit. Every day something's worse. I see my daughter there every day. She can't spend time with her. My granddaughter every day. Day in, day out, I'm getting worse. I do not want my kids to be burdened by me either. I think that's a normal thing. If I know I'm dying anyway, I do not want them to sit there suffering because I'm dying a very slow, miserable death. So I think it's completely reasonable for people to care about their family members, and that is always part of how we make our decisions in life. We think about all the people around us who do we care about, what impact do we have on people. And so, yeah, it shouldn't be just to feel because we feel we're burdened, but it is part of the decision making.
And we've heard from people in the disability community who are concerned that people might choose MAID because their quality of life is so bad, or they're forced to live in poverty. What do you make of those concerns?
Now, that's always a really big discussion, and it's always been a worry, of course, because people who have disabilities, they're not only devalued by society often, but they devalue themselves because you take on what people think about you. So that's always a worry to us, that we don't want people with disabilities feeling that they are worthless, that they're better off dead. So that always something to be worthwhile, and that is why for people who are track 2, so what track 2 is, people without reasonably foreseeable natural death. So that became legal in March of 2021. And so that generally captures most of those folks with developmental disabilities or other disabilities that don't have a quick death. And we have long been concerned about that. So the big goal for those people applying is for us mostly now to find a solution for them to have a better life, as opposed to move on with MAID. So it is very time intensive for us, because we want to make sure the right thing happens. Now, I have had a number of people who have disabilities, and basically almost none of them will have moved on to MAID. Only one that in my practice moved on to MAID, because we're very connected in Saskatchewan, and we're able to find solutions for people that can move on to have a bit of a life, and that's what we should be doing. It makes it very intensive, though. So if I'm taking an assessment that's track 2, somebody not dying quickly, that generally has a disability, that is very time intensive and often takes a prolonged period of time to make sure the right thing happens for that person. And often it does. When people are hooked up with resources, they talk to someone, they are in a place where they get human beings that respect them and so on, they often don't want to die.
Okay. Just a quick note here from Denise, who wrote on Facebook, I enjoyed this process with my sister in April 2020. So happy it's available. Very surprised how few Canadians I talk to are unaware of the MAID program. I'd like to see more awareness. That came to us from Denise. Now let's go to the phone lines. Maureen is in Regina. Hi, Maureen.
Hi, Garth.
Go ahead, Maureen.
I had to pull over and comment. I've had chronic illness and since I was in my 20s, and I'm approaching 60, a little faster than I'd like to admit. It's so wonderful to hear the progress that's being made, and I just really wanted to comment on how, you need to look at the full person, and quite often with chronic illness and disability, you're going to get levels of mental illness and depression and anxiety that go hand in hand with that. So we have a system that does devalue people and that can, really have a negative impact on them because of poverty, because of, like your guest said, people can take on this feeling that comes from our culture. So this discussion is really an important culture-changing thing. We need to look at the quality of life, why people would want to look at MAID, and what we can do to help get rid of any stigma that causes family members and loved ones to resist the fact that, really our final act of autonomy and freedom is to choose if we want to die. But there should be those supports in place to help people. There needs to be better health supports that look at the entire human being's life and what can be done. But if MAID ends up being what needs to be done, we need to get out of the way.
Okay. Maureen, thanks so much. Dr. Thorpe has been nodding, so we'll bring Dr. Thorpe in. Yeah,
those are such good comments because, we have this, the term, we call this ableism, whereby we value people for what they're able to do and people take on that devaluation of themselves. So we have a ways to go. There's much we can do in terms of function, improving people's function and accepting that we're all at different levels. We're actually all disabled in many ways. Like some of us are physically disabled. Some of us maybe have trouble actually even with our own empathy, with our relationships with others. We all have sorts of ways, things we can do well, things we cannot do well, and we in general have to continue moving towards a just and fair society where we allow access to people on a fairly equal basis to resources, to training, to learning, to jobs, physical accessibility. So one of the fellows I assessed with cerebral palsy, I mean, it's hard for him to get around. Like we have to continue improving things like ramps on the sidewalk so people can move their wheelchair around. People have to be able to have ramps up to buildings. So even public buildings sometimes don't have good accessibility. So when we can gradually optimize some of those supports for the younger folks with disabilities, this is all going to benefit all of us, especially as we get older, that we all develop various disabilities. So this is all really, this whole MAID process has made many of us really think about what we can do to better the lives of many of us, and not just in the dying process, but in how people feel about themselves and how we may be able to make some of those changes happen.
Okay, I want to get to this question real quick from Anne on Facebook concerning MAID. If you are incapacitated, can your medical POA enact MAID on your behalf if it's in your POA directive?
No, actually not. So the advanced directives are actually quite specifically different, and it's not yet legal to have an advanced directive, which means a far ahead decision that if something happens, you could have made. That's not yet legal, and your power of attorney cannot consent to that. So now there's been discussion at the Senate level, and I was actually invited to present at the Senate on this, on advanced care directive. So it's actually quite complicated because people change over time in what they want. So what we think we wanted to do with our lives 10 years ago might be quite different than now. And as people gradually change, their wishes might indeed change. So right now, the short answer is no, it's not legal yet. Yes, it might become legal, but it's going to have some really careful safety guidelines around that to deal with the fact that sometimes people change and they may not want what they thought they wanted 10 years ago.
Okay, we've only literally 2 minutes left, and I want to. There are those who argue that MAID has put us on a slippery slope. That now it's people that are near death, and then it's going to be people with difficult mental health issues, and eventually, how long is it before it's infants with a disability? What are your thoughts? What do you say to those folks?
Well, it's certainly been a slope, and I would agree that it's a bit of a slippery slope right now. I feel that the original law for people who have reasonably foreseeable natural death was I think fairly acceptable to most people. Many people actually do not support Track 2 for people who are not dying quickly, and people are quite worried about how fast this is going because we actually have to do a lot of education as well before we move into those stages, and that's why it was actually deferred just now. This MAID for someone mental illness, I think it has moved very quickly, and anything needs education and learning and safety measures put in and so on. So many people would think it's maybe a bit fast, although if you talk to someone who's got one of those really severe mental illnesses that has had everything, and I've seen patients like that, they are going to say this is not fast enough. So I think there are going to be people who are really, really, really struggling and feel they need this, but many of us also do worry a bit about how we're going to do this quickly and make sure it's also safe.
All right. Dr. Thorpe, thank you so much for coming in and sharing your expertise with us. It's been a pleasure. Thank you so much.
You are very welcome, and good luck, everyone. Thank you for the wonderful questions.
Dr. Lillian Thorpe is a geriatric psychiatrist and professor of psychiatry and community health and epidemiology at the University of Saskatchewan. All right, that's our time together for today. Tomorrow, there are many veterans, retired police officers, and first responders who suffer from PTSD. In Regina, some of these people have formed a group to support one another. One of the things they have in common is their use of medical cannabis. Tomorrow on Blue Sky, we'll talk about cannabis and its use in treating depression and PTSD. That's tomorrow. Talk to you then, folks. Thanks for listening. Bye now.